Good morning, everyone. I am presenting a rare case of juvenile X-linked retinoschisis in a young male. X-linked juvenile retinoschisis is a condition characterized by symmetrical bilateral maculopathy leading to impaired vision that begins in childhood. It is seen almost exclusively in males with a prevalence of about 1 in 15,000 to 1 in 30,000. It arises as a result of inherited defects in Muller cells. It occurs due to splitting of the RNFL from rest of the sensory retina, in contrast to acquired retinoschisis, where splitting occurs at the outer plexiform layer. Inheritance is X-linked recessive, with RS1 being the implicated gene in most cases and the protein being retinoschisin, which is involved in intercellular adhesion. I am presenting a case of 17 years old male who presented to IOPD with complaints of diminution of vision in both eyes for about 4 years. The patient was apparently well 4 years ago when he developed diminution of vision in both eyes, which was insidious in onset and progressive in nature. It was not associated with pain, redness, watering, or discharge. History of spectacles use was present. There was no history of diabetes, tuberculosis, or any other systemic illness. There was no history of previous ocular surgery or trauma. There was no significant family history. Personal history: vegetarian with normal sleep and appetite, normal bowel and bladder habits. There was no history of smoking or drinking. On general physical examination, patient was well nourished, conscious, alert, and well oriented to time, place, and person. His vitals were stable with pulse rate of 72 beats per minute, blood pressure of 126 by 78 mmHg, respiratory rate of 14 per minute. He was afebrile to touch. There was no pallor, icterus, cyanosis, clubbing, and edema. On ocular examination, best corrected visual acuity was 624 in right eye, 618 in left eye, with +1 diopter square in both eyes. Head posture was within normal limits, head nexa was within normal limits, eyeball was normal in position, normal in alignment, and ocular movements were free and full and painless in all directions of gaze. Conjunctiva was normal, showed no congestion, chemosis of foreign bodies. Sclera episclera showed no discoloration, nodule, or laceration. Limbus was normal, no vascularization pigmentation seen. Cornea was clear in both eyes. Anterior chamber showed normal depth, no cells, blood flare or hypopyon seen. Iris was normal in pattern and pigmentation. Pupil was 3 mm round, responding to direct and consensual light reflex. Lens was phakic in both eyes. Fundus, disc margins were sharp in both eyes with CD ratio 0.3:1. Foveal schisis was seen, giving the appearance of spoke-like stria radiating from the foveola. IOP was 13 mmHg in right eye and 14 in left eye. These are the fundus images of right eye and left eye, showing foveal schisis, giving the appearance of bicycle wheel-like or spoke-like stria radiating from the foveola. And these are also the fundus images, same patient. Investigations: a provisional diagnosis of juvenile X-linked retinoschisis was made, and he was advised to undergo bilateral OCT, macula, and FFA for documenting maculopathy and its progression. OCT in both eyes showed intraretinal foveal schisis with cystic spaces, as we can see in this image here. FFA could not be done as patient did not give consent to get it done from outside, and we did not have the facility working at that time in our institution. Management: the patient was prescribed oral acetazolamide BD and topical eye drop dorzolamide TDS to reduce foveal thickness and improve visual acuity. He was educated to avoid high impact sports due to the increased risk of retinal detachment. Genetic counseling of the patient and his family was done. He was followed up at short intervals to look for secondary complications. At 1 month, his BCVA was same with no secondary complications. Conclusion: juvenile retinoschisis is a rare disease belonging to a group of hereditary vitreoretinopathies and is characterized by bilateral maculopathy. Inheritance is X-linked recessive. Progressive maculopathy often leads to poor prognosis. Visual acuity often deteriorates during the first 2 decades and then stays stable until the 5th or 6th decade. It has been seen that clinical course of disease gets complicated by vitreous hemorrhages or retinal detachment in approximately 5% of all affected males, where we might need surgery. Although we have made significant progress in understanding of the disease still has many unresolved issues that require further study. Thank you, sir.
Is there any family history of the same problem?
Actually, he did not give any family history. Maybe it was unknown, or maybe it is because of asymptomatic female mother of the patient. Because mothers are usually asymptomatic, patient might not be knowing.
Did you ask for a genetic test or gene mapping or something?
Yes, sir, but it was very costly and we could not get it done actually.
What you see on FFA, what you are expecting on
Yeah,
FFA?
sir. On FFA, we are expecting window defect in later stages, maybe due to RP atrophy in later stages, and that's how we can differentiate from cystoid macular edema as well, where there is leaking in petaloid appearance.
Leakage in a macular edema. Here you won't get leakage.
Here we will get window defect due to RP atrophy, sir.
What are the gene studies going on in X-linked? Are you aware
Yes, sir.
there are trials going
Yes, sir. There are two NIE and AGTC. There are two trials going on for. Sir, one of them showed like improvement in cavities, foveal schisis cavities, that showed decrease in the cavities, but not much success due to inflammation. Ocular inflammation was there, and also with the same AGTC was halted because of the ocular inflammation that went, with not much of success there.
Thank you, madam.